name. Whosoever is unmuted themselves, just mute yourself. Don't say, okay, sir, sorry, sir, I will do it, this, that. Don't make the conversation longer. Just unmute yourself if I tell your name. That's all, nothing more. So, since we are doing PGDMS, that is basically for, we are going to learn something to prevent death. And death eventually, last word for death is a flatline ECG. So CVS becomes one of the most important chapters, and we start with that important chapter, CVS. Okay, in CVS, we learn something about heart, we learn something about blood vessels and lymphatics. 3 things we will learn basically. Little of general anat also today, only today, nothing more. Afterwards, no general anat. So there are only 2 types of specialized tissue in the body. One is muscle tissue and nerve tissue. When we say specialized, that means it will be specialized in structure as well as in function. Anything which has a function should have a corresponding structure and vice versa. Now, the speciality of the function of the muscle is muscle can only contract. It can never expand. Please remember that muscle can never expand. Muscle can only contract. It can only become smaller. It cannot become bigger. And what is smaller and bigger, we will see in the next slide properly. Wherever there is movement, whenever there is movement in the body or of the body or in the body, both of them, thus movement can only occur due to contraction of muscle. Muscle contraction is the main thing responsible for movement. And I'm using 2 words, movement in the body and of the body. So the easy way to remember is M is to M. Movement, if it is needed, there has to be a muscle. Okay. Now what happens is, which are the types of muscles that are there? There's a list. This list is not what I'm basically interested in teaching you. I'm not interested in teaching you this. What I want you to understand is, if we ever do classification, then classification always has to be done on one criteria. So depending upon many different criteria, there are different type of muscles that are present, but you have to do according to criteria. Criteria is very important. So if we are classifying muscle according to location, means where the muscle is situated, then we have 3 examples. Skeletal, that is the one which is attached to the bones. Another is one which is in the organs, therefore called visceral. And if you want to learn from now onwards for the rest of your life, please learn Greek. Greek is very important. As I'll keep telling you again and again throughout the lectures, Greek is very important because the word viscera means organ. This word means organ. So if you know the Greek word, then the English word becomes simple and your understanding will become more simple. So skeletal muscle means the one which is attached to the bones, which are basically going to move the body, right? Next, we will do what is body before we go to CVS system. Then viscera is that which is found inside the organs. And of course, everything, one organ is always standing out special, and that is the heart. Correct? It is not only in medicine or in our body, this heart is standing out clearly. It has been standing out for lots of centuries. All poets have brought out heart. In all Bollywood movies, heart is always involved. There is a fair exchange of heart between the hero and the heroine. And so this heart has always been in picture for thousands of years, including anatomy and in medicine. Today also, one of the most dreaded diseases is heart attack. God knows why it is so much dreaded. Hundreds of people go to the hospital and come back after a short stay in ICU and all are alive, but still the fear is maximum in myocardial infarction, not that much even in cancer. The biggest fear of any disease is this. Anyway, so that's enough about a lot of heart. If we take a section of any organ and see under the microscope, which is also known as histology, then if we see the muscle is having striations, something like this red thing, if the muscle is having striations like this, then we call it a striated muscle, right? This is a striated muscle. If the muscle doesn't have any striations like this, then we call this a non-striated muscle or a plain muscle. And every book, most of the books, 99% of the books calls this a smooth muscle. And I've purposely retained this name in some of my slides also, just to show you, see how this wrong nomenclature is existing. A muscle cannot be smooth. Smooth is a feeling. Smooth is not something which you can see by sight. Please understand this. Sight cannot show you smoothness. Smoothness is a feeling. And therefore, you can't feel this muscle to be smooth. These two, you can't feel that they are smooth. Because to feel that they are smooth, you have to put your fingers between the microscope and the slide, which is not possible. Or rather, between the cover slip and the slide proper, the tissue proper. So this smooth is a wrong word. But as I'll tell you, we are going to learn lots of long words in medicine. And because the others are using this word, we will also be using the wrong word. And we'll keep talking wrong things. But there is nothing like smooth. Please remember, it is plain or it is non-striated. Then based on function, it can either be voluntary or it can be involuntary. Again, voluntary is those which are there in our body, which we do according when we want to do. Like if I want to pick up a glass of water and take it to my mouth, that is voluntary. Involuntary are the muscles which are there in my organs. But again, the same thing does not apply true because tongue is an organ and tongue can tell you any number of lies. So it's voluntary. Okay, it is not involuntary. If the tongue was involuntary, we would never be able to tell lies. So the basic thing depends upon any one criteria. You cannot mix 2 or 3 criteria together and use it. So each different criteria tells us the muscle differently. So this is striated muscle. This is plain muscle or non-striated muscle, which every book will keep calling this smooth muscle, including some slides that I'll show you. And this is, of course, cardiac muscle, the lower one. This is the heart muscle or the cardiac muscle. Okay. The peculiarity of the cardiac muscle, why it doesn't fall into this category, is that the cardiac muscle branches. This is a branch of the cardiac muscle. So each cell, when I'm saying cardiac muscle, I'm talking about the cell, and each cell of this will branch. See, these are branches. And the branches of one cell will unite with the branches of the other cell. And we'll see this later, this peculiarity later on. So now, when I say there is movement in the body, I would like to tell you a few things so that you remove this misconception that the muscles are not moving in the body. So this is kidney. As you know very well, these are the ureters, and this is the urinary bladder. So what happens is a drop of urine is formed in the kidney, and this drop of urine falls down into the bladder. So it is coming down from this side, it is coming down from that side, it is collecting the bladder, right? And then it is being voided outside. This drop of urine that we think and we talk is coming through the ureter like this. It is not coming. Please remember, it is not coming because what happens is in the night we are lying down like this, right? This is the body and we are lying down like this. And if this was true, then from the kidney, the drop of urine will not go like this because there is no gravity. And we know it doesn't fall below the bed, that is 100%. So it is definitely going via the ureter to the urinary bladder. And all of us have experienced in the morning that the bladder is full. And that means the urine has traveled from the kidney to the bladder, not by gravity, because gravity is not working here. So this drop of urine travels by contraction of muscle. This is the contraction of the muscles which are there in the ureter, which are allowing the drop of urine or are moving, to be precise, they are moving the drop of urine from the kidney to the bladder. It is the actual contraction of this ureteric muscles which is doing it. Okay. Suppose this is the mouth and this is the tongue. Like this is T written on it, but the T has merged with the tongue. So let's say This is tongue. Okay. And this is below the mouth. There is salivary gland here. Salivary gland is somewhere away from the mouth. It is not in the mouth. So God has made us so nicely. If the salivary gland was inside the mouth, we'll swallow it every time we eat food. So the salivary gland has to be outside the mouth. But from here, the saliva which is made has to go and open in the mouth. So the duct which is carrying this, it is not like a pipe and the saliva is just flowing in it. Each drop of saliva which is formed in the gland is transferred to the mouth by active contraction of the muscles. And this is what I was meaning when I said that muscles contract in the body and muscles of the body contract. Okay. So these are the, sometimes I'll just write the things for you to read. So you can read this. I don't know how to take this up. Okay, it's gone. Plain muscle. That means the one which is inside the organ. Striated muscle will be in the skeleton and the heart. And, or rather, I will do this slide after 1 second. So for 1 second, we'll skip this slide and we're going to the next slide. Okay. Now in this slide, all this you know very well. I'm just showing you what I'm talking. This biceps muscle, which is in front of the elbow joint, right? It has crossed the elbow joint in front of it. And if this biceps muscle contracts, then what I want you to understand is it is becoming smaller in size. It is becoming smaller in size. But because of its at least minimum 2 attachments to minimum 2 different bones, because of its attachment to 2 different bones, what happens is if this muscle becomes smaller, then one of the 2 bones moves. So this bone which was here, the biceps like this, has moved from here to here. So it has moved like this. So it is because of the active contraction of this muscle on this joint that this joint has moved. And because the joint has moved, there has been movement. Okay. In this case, the triceps is not moving. The triceps has not moved. The triceps is there only. So this movement which occurs in front of the elbow joint, we call this flexion. Keeping it there only, they are seeing something else. Now this is the length of the muscle. So this is the length of this muscle when it is not contracting, when it is not doing any function. And when it contracts, C stands for contraction, it has become shorter in length. And when it relaxes, it comes back to its original length. Please remember, in relaxation, the muscle does not become longer. Muscle does not become longer than the original length, right? Because this expansion, this diagram which is showing expansion is not possible. No expansion is possible. Muscle can only go back to its original length when the muscle relaxes. And when the muscle contracts, it will become smaller. Okay. So the logic is that the muscle can push. A muscle can only pull, not push. Muscle can never push. Muscle can only pull. And that's why it will cause movement. That is the logic. Now, here, going back one more slide, we saw that the striated muscle, which is there in the skeleton and in the heart, this muscle needs to have attachments. Only if it is attached to some skeleton, then it can contract. So here we saw that the muscle is attached to 2 different bones, right? One is scapula and another is the radius. Similarly, if it is that is true, then the heart muscle also, if it needs to contract, it should be attached to a skeleton. It should be attached to a skeleton. Now, this is how you learn basics. If we say, yes, this is the rule, then that rule has to stand. Then whether you know there is any bone in the heart or no, it doesn't matter. But the rule remains the rule. Basic rules can never be compromised. Skeleton might not be bone. Skeleton might be something else. But the rule remains same, that if there is a cardiac muscle in the heart, this cardiac muscle needs to have an attachment for it to contract, for it to function. Okay, as we go along, we'll see that. So coming back to this. So now the biceps muscle, when it got stimulated by one nerve, when this nerve, N nerve came and stimulated this biceps muscle contracted. Because the biceps muscle contracted, this has moved like this. And this is what we call flexion of the elbow joint. Now, how does extension occur is the question. In extension, what happens? We want to know. Now, in extension, the triceps muscle cannot become longer. So what is happening when the flexion is occurring? And this flexion is occurring, let's say, for example, because I want to bring the glass of water towards my mouth. Have you ever thought that, hundreds and thousands of times you have picked up the glass of water to drink, and even with your eyes closed, that glass of water has never gone into your nose or into the ear or the eye. So the coordination is so nice. Perfect coordination is there. It will never go anywhere else. So supposing I pick up a glass of water, my biceps is contracting, my elbow is flexing, and I brought the glass to my mouth. Once I finish drinking, I want to put the glass back. I don't want to hold sitting there, holding the glass near my mouth only. To do that, I have to undo flexion, means extension has to occur. And extension here is not a passive process. It is not just happening because biceps, which had become contracted smaller, now the biceps is becoming back to its original length, means it is growing in length, and that's why extension occurs. No, it's not like this. What happens is that the triceps muscle during flexion had got pulled. See, this tricep muscle which is attached here, has got pulled so much. It has got stretched. Because it has got stretched, it has pulled. But this stretching is within its normal capacity, within its elasticity. That means it is not tearing. It is just getting stretched. When it is getting stretched, it sends a signal to the brain that I am getting stretched. I am getting stretched. Please do something. Brain says, keep quiet till the glass reaches the mouth. You will have to suffer the stretching. Once the function for which biceps was contracting, that is the glass to reach my mouth, is over, the brain will listen to the triceps now, and the brain will send down a message. Now a message is coming, motor impulse is coming from the brain to the triceps. And the triceps is now going to contract. Because the triceps is getting stimulated. So the stretched, the one which was looking elongated because it was getting stretched, this muscle will now contract. When this muscle will contract, this which was here will go back to its original position like this. So extension is also an active process. Extension is done by another nerve, the nerve which does not do flexion. The nerve which did biceps flexion was this nerve, black color. And the nerve which does the movement or the contraction of triceps is the red color nerve. So they have to be different nerves. If it's the same nerve, biceps and triceps will contract at the same time and there will be no movement. So for movement to occur, we need joint, at least one joint. The muscles which are causing movement have to cross the joint, both sides. On the opposite sides, they have to cross the joint. There should be at least two muscles which are going to do opposite function, and there should be at least two different nerves which are supplying the two muscles differently. Two different nerves, two different muscles on opposite side of the same joint, then the joint can be moved. This is contraction in simple words. I hope it looked simple. But then when I was teaching once, one of the batch students asked that, sir, you're saying that the muscle cannot become big. That time I had used the word wrongly, big, instead of saying in length, it becomes longer. So when I use the word big, they said that muscle does become big. And so this rest of the diagram has been put for your understanding that if this smooth muscle has increased in its size, right? Or if this striated muscle has increased in its size, then that we call hypertrophy. Again, you have to learn Greek. Hyper word means more. Hyper word means more. Trophy means growth. Trophy is growth. Okay. The word trophy means growth. Remember these words, simple words, but once you learn the Greek, then it is simpler. Also, please remember, this is now I'm giving you HW, so don't answer, don't tell me. There is a different word called hyperplasia. This is hypertrophy. And there's a word called hyperplasia. Please find out the difference between the two, because whenever we talk about prostate becoming bigger and we use the word BPH, benign prostatic, it is hyperplasia, not hypertrophy. Please remember that. So do the difference between hypertrophy and hyperplasia yourself at home today. And when you want to learn Greek, don't go and look at the meaning of the word in Google or in the medical dictionary. Because, for example, if you want to know about clavicle, then the meaning given is clavicle is a horizontal bone situated between the arm and the chest or something like that, depending on how much you want to see. If it's in the medical dictionary, the words will be much better. But that is not what I'm meaning. What I'm meaning is find out why the bone is called clavicle. This bone is called clavicle because the word clavus in Greek means key. And the first time somebody saw this bone, now remember when the person saw this bone, we are not talking about yesterday and today. We are talking of long time back, hundreds of years. The word clavus means key because those days the lock was simple, the key was simple. And that's how the word clavicle has come. So please read, see the derivative of the word. Find out in Google where is the word derived from or what is its Greek origin or Latin origin. And that's how you learn. And that is very, very important. Now we'll go on to heart. We'll start with heart, then we'll do blood vessels, and last we'll do lymphatics. And this is the heart. The location of the heart, all of you know where it is. So some of you will say it is in the chest, some will say it is in the mediastinum, blah, 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 blah. Many answers will come. But if I want one word answer, then whatever you learn last, that is in medicine or in surgery, that is what you should remember. So if I ask you in one word, where is the most common pain of myocardial infarction felt in one word, then the answer is retrosternal, behind the sternum. And therefore, where is the heart situated? The heart is situated behind the sternum. That's all. Then the sternum, somebody has to know that the sternum is a bone in the chest. If they don't know that, that's not your problem. Okay, so right in the middle of the chest, behind the sternum, that is the heart. And on either side of the chest or the thorax, there are two lungs. So the chest or the thorax becomes the most important organ, important part of our body, because the two most precious organs are in the chest. One is heart, one is lungs. These are all useless details put for you, absolutely useless ones, because you are not going to come in contact with any of this. This is all blah, 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 blah. No need at all. And there are, all I want you to know is that there are 4 chambers, which you know very well. 2 are called atrium and 2 are called ventricles, right and left. And as we go along, we'll see all this. Now, some words which are interesting, and these interesting words you should know. So let's see. Now see how wrongly words are used. So there is something called coronary sulcus. Now the word sulcus, we stop at the word sulcus. Sulcus means a linear groove. Linear groove means in simple Hindi, it is a gutter. By the side of the road, you see there is a gutter in which water is flowing. It's a linear depression. What you see on the road is a khadda. Khadda is a fossa. So we are not talking about road, khadda. We are talking about the end of the road where there is a line depression in one straight line, and that is called gutter in Hindi, and it is called sulcus or groove in Latin. So both words mean same, groove or sulcus. Okay, groove or sulcus is the same meaning. Now, this coronary sulcus is between the two atria and the two ventricles. But here we have used the wrong old word of 12th standard. So this is just to draw your attention that auricle is no longer used in the body. In our body, we use the word atrium and the word ventricle. Auricle is a part of the atrium, as we'll see later on. And auricle, if you remember auricle, the Greek word, auricle means ear. So a part of the atrium which looks like the external ear is called auricle. So the coronary sulcus is between the atrium and the ventricle. So if this hand of mine, this fist of mine is the atrium, this fist of mine is the ventricle, then in between them 360 degrees, whatever you see, that sulcus, that is coronary sulcus. Okay. And in this coronary sulcus lie the coronary arteries. So instead of saying coronary arteries, specific words have been used. Contains trunks of nutrient vessels. Nutrient vessels means vessels which are giving nutrition to the muscle or the myocardium. And that is the coronary vessels. They are called coronary because they are lying in the coronary sulcus. Okay. The word coronary has nothing to do with heart. Please remember. Let's go back again and see this. The word corona is something like this in shape. And the word corona literally means the crown. Corona literally means crown. So crown is that thing which the king wears on his head, you know. And because it has to fit on the head, it always has to be round. It has to be round like this because it has to fit on the head. Okay. So something which is round is called corona. And that's how the virus, which is now in existence since last 3 years, troubling us, that virus is like a crown shape. And that's why we call that coronavirus. So the word coronary is something which is round like the crown. Okay. It has nothing to do with the word heart. The word heart, Greek word for the word heart is cardia, or cardiac to be precise. Cardiac. This is one place where we don't use the word cardiac arteries. We don't use the word cardiac arteries, but we use the word coronary arteries. And therefore, all the diseases become coronary artery diseases. Right? There is nothing like cardiac artery disease, whereas correctly it is a cardiac artery. But we are going to call it coronary because it lies in the coronary sulcus. And therefore, you should know the meaning of the word corona. Corona means the crown. That's why the day the king, now you must have heard in Britain, there's going to be a king who's going to have the coronation ceremony in this year, sometime in June or July. So in June or July, because of the coronation ceremony, that person will become king. So coronation is where the king will wear the crown, right? That much is enough. This is how the heart looks in a dead specimen lying in situ. What you see has been cut from here and put here and here and here. This and this and this, 4 things that have been cut because the cut was given like this. And these 4 flaps have been removed. That is called pericardium. And this is one lung and this is another lung. Okay. So those are the 2 lungs and this is the heart. And that what we have cut is the pericardium to see the heart. So the heart is situated, as we learned in the college, in this empty space which is here, which is called the mediastinum. So first in the college they made us define what is mediastinum. Mediastinum is an empty space which is there between the 2 lungs above this blah 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 blah, and then they said it is containing all these structures, and therefore there is no empty place. And why did we start with an empty place? God knows. Anyway, we are not bothering with what we learned. We can unlearn that. What I'm interested in showing you is this is the diaphragm. Please understand this very, very clearly. This is diaphragm. And the lungs are on the diaphragm. The base of the lung is on the diaphragm. Also remember, this is three-dimensional. We are not able to see three-dimensionally, but that is the base of the lung. The lung is fully sitting on the diaphragm. This will become very important when we are doing RS. And whatever is this diaphragm is, a diaphragm is like an open umbrella. Diaphragm is like an open umbrella. That is what you have to remember. So this is the umbrella, and this would be the stick of the umbrella. It's like an open umbrella. Okay. And so if we see this side, here, though there is lung over the diaphragm, I hope you can make out the brown color is the diaphragm and that bluish purplish color is the lung. At that same point, here under the diaphragm, there is liver. Liver is there right under that same diaphragm. And over that same diaphragm, there is lung. This is very important. Because what happens is, in colleges, the lung and the heart is there in volume 2. It is taught at a different time. The organs of the abdomen are in a different volume, taught at a different time, preferably by a different teacher. If you have lots of teachers, if not, the same teacher will teach. But the two things are taught at two different times, and they are also there in two different books, and questions also come from two different sets. And therefore, in our thinking, thorax is different, abdomen is different. Please remove this concept. Now you have to put everything together. That the part of that an organ which is below the diaphragm on the right side is liver, and same time the right lung is above it. Similarly, on the opposite side, that is on the left side, there is an organ called spleen here, which is just deep to the lung. Spleen is here, which is deep to the lung. Stomach is here, which is deep to the lung. Right? The transverse colon is there, which is deep to the lung. So the structures in the abdomen and the lung are in the same place in horizontal line or anterior posterior line. Why this becomes important is, if a knife or a bullet is going to travel from here in the body, right? This being thorax, this being 9th rib or 10th rib or 8th rib or 9th rib or 7th rib, don't think that this is going to travel through the lung only. It is going to travel through the lung and the liver and the pleura and the peritoneum and the diaphragm. It is going to go through everything, or the knife is going to go through everything. Therefore, what I am trying to tell you is that the lower half of the chest wall, is upper part of abdomen. Lower part of the chest wall is upper part of the abdomen. Just because there are ribs there doesn't mean it is still thorax. It is still chest. It contains lungs and heart. It contains all abdominal organs. And most of the important abdominal organs are in the upper part of the abdomen. Stomach, spleen, liver. In terms of bleeding, these all organs are full of blood and they can bleed. And if a person bleeds, the person can die. The inferior vena cava, the aorta, all important big organs which can bleed are in the upper part of the abdomen. Right? Remember this, that lower part of the chest wall is upper part of abdomen. This is stomach, which you can see very clearly here. There will be liver here. Of course, spleen is even behind the stomach somewhere in that region. Upper part of the kidneys are there. Upper part of both the kidneys will be there. So this becomes important for us. We have not ever been taught heart and its relations with the stomach, lungs and its relations with the liver or the stomach. We have never learned. We have learned lung as lung and abdominal organs as abdominal organs. Please now incorporate this into your head that they are together. Unless you incorporate and have a picture like this in front of you, where the chest and the abdomen is one continuous thing. Only when this is there, so that behind here, if you can imagine that there is a esophagus, which is going to come and open into the abdomen. This esophagus is behind the heart. That's why myocardial infarction can mimic esophagitis, or it can mimic hyperacidity or esophageal reflux. Because the location remains same. Location remains same, right? That is how you should understand from now onwards, that it is this togetherness which is correct and not solitary like we are doing like this. Lungs are separate and lungs and heart are in the chest, and abdomen has nothing to do with it. Abdomen has everything to do with it. They are all in close proximity. That means if you ask me what is the inferior relation of the heart, I will say liver, because it is sitting on the liver. That is its inferior relationship, and the fundus of the stomach. And that's why, if you remember now, if you think about it, that in the X-ray of the chest, you could see the shadow of the air in the stomach in the X-ray of the chest. That is because when we do three-dimensional, that fundus of the stomach is somewhere at the level of here. See, this is the lesser curvature. This would be lesser curvature. This would be greater curvature, and that will be the fundus. And therefore, the gas in the fundus of the stomach will be seen in the chest X-ray. Right? I hope I have convinced you to see some pictures, nice pictures. Go ahead and see them. Get an understanding of the body being one and not parts. This is the heart, and that is the lung. The lung covers the heart, and unless we use retractors like this, you can see there are 4 retractors placed, and because of these retractors, when the anterior border of the liver is moved, we can see the heart in total, right? So this is the heart seen. We'll do the writings afterwards. Again, this is the heart which is seen, and this is the lower border. Okay, this is right, this is left. Sorry. This is left, and that is the superior. But superior border is never seen. Superior border is never seen, and the words that are used in the book is that the superior border is not seen due to the emergence of the great vessels. Emergence of the great vessels. That means this is SVC, which is coming into the heart. This is the aorta, which is coming out of the heart, and that is the pulmonary trunk. So these 3 great vessels, they are entering or leaving the heart, and that's why we'll never be able to see the superior border or the superior surface. Other things can be seen easily. What I want you to appreciate here is the word that we learned some time back. This ear, external ear-like thing, this is called right auricle, and this ear-like thing is called the left auricle. So auricles are the last part of the atrium. You heard it today. After today, don't even bring that word auricle into it. It is always atrium and atrium. Okay, that is very important. Also, what I want you to understand is there is lots and lots of epicardial fat. This yellow thing that you're seeing, this is called epicardial fat. Epi means above or also outside. Epi has got 2 meanings, above and out. Okay, 2 meanings are there. And this epicardial fat is completely surrounding the heart. It is so much completely surrounding the heart that these vessels, which in this is diagrammatic and they have been drawn here outside clearly, they are not seen clearly like this. The blood vessels are embedded inside the fat because the blood vessel is in the sulcus and the fat is covering the sulcus. So they are inside. This is a diagrammatic thing just drawn for us to see. This is all words, nothing much that you should do. If you notice that there is one brownish line drawn here, this line has been drawn by one of you or a child in the house who picked up this EndNote pencil from here, from the top, and has drawn it. What will happen is that this brown line will be there in every slide. Unless the person from whose house it has been drawn rubs it out, this brown line you'll see everywhere in each and every slider. So please don't allow children in the house, or you don't take that pencil from above and draw anything. So there are anterior surface of the heart, which is also called sternocostal. Inferior is diaphragmatic surface, where it is on the diaphragm. Superior surface, as I told you, is not seen because of the emerging great vessels. Now the important, only this word you have to remember. The posterior surface of the heart is also the base of the heart. Because the base of the heart will be used in angiography, and if you don't know base of the heart, and if you mix up base of the heart with inferior surface of the heart, then there'll be a problem. Base of the heart is the posterior surface of the heart. We'll see some slides properly to understand this, but why this nomenclature is like that. So whatever word is used, whether it is botany, zoology, anatomy, geometry, algebra, wherever, because it has a Greek origin, the word remains the same. It cannot change. So this is an angle. An angle is where two lines meet, right? That is the angle. And in triangle, because there are three angles, we call that triangle. If this is the triangle, if I take this to be the apex, then the side which is opposite the apex is called the base. If this is the apex, naturally the side opposite is called the base. So in heart, this is our apex. The apex of the heart is, see again somebody has drawn here, same color. This is the apex of the heart. If this is the apex of the heart, this cannot be the base, because the side which is along with the apex cannot be the base. Apex is something which is opposite, so you have to go opposite like this, and it is three-dimensional. So the one which is opposite the apex is the posterior surface of the heart, and posterior surface of the heart is called the base of the heart. Okay, please remember only this much. Rest of the things you can forget. Of course, like borders are there. That border is there, and those borders are formed by, you don't even have to learn all this. There is no meaning. This is the picture of the heart. Okay, so the big vessels which are emerging, they are always like this: blue, red, and blue. Blue, red, and blue, like that. So the first blue on the right side is the superior vena cava. The last blue on the left-hand side is the pulmonary trunk and not the pulmonary artery. And in between is the aorta, the biggest artery of the body. Okay. So since the superior vena cava is coming and opening into this chamber is called right atrium. The chamber which receives all the blood from the body is the right atrium. It receives all the deoxygenated body. Please don't use the word impure blood. Don't, especially in front of patient, use the word impure blood. The word is deoxygenated blood. Deoxygenated blood will come into the right atrium, and then it has to go into the right ventricle. So the right ventricle has to be right next to it. That is the right ventricle. And from the right ventricle, it is going to go via the pulmonary trunk into both the lungs, into each lung by its own pulmonary artery. Okay. So here, in between the two of them, between the right atrium and the right ventricle, this is the right atrioventricular groove, or a part of the coronary sulcus. And because as a part of the coronary sulcus, we can see the right coronary artery lying in it. This is one ventricle. This is the other ventricle, left ventricle. And these two are there anteriorly. We can see both the ventricles by the side of each other. and there is a groove in between these two. The groove in between the two ventricles will be called interventricular groove. And in the interventricular groove, there will be an artery called the anterior interventricular artery. Anterior interventricular artery. And then when we do coronary circulation, we'll see that clinically we call this artery LAD, anterior descending artery, right? But right now, as we are doing interventricular groove, this is called anterior interventricular artery, which also tells you that there must be a posterior interventricular groove. Otherwise, we wouldn't have called this anterior interventricular groove. So this groove is going to go posteriorly also like this. And there's a posterior interventricular groove. And that becomes very important when we do coronary circulation. This is again giving you an idea of the diaphragm. The diaphragm is like this. And where you see this whole black thing inside, that is where the liver is going to be. And this is where the lung is going to be. Okay. So that is that much. This, if I lift the diaphragm from here upwards like that. So if you can imagine, this is a basket like this, instead of it being a umbrella, if you think that this is a basket like this, and this is the thing, then I'm lifting this basket from here. From here, I'm picking up the basket. Okay, I'm lifting the basket like this. If you pick up the basket, then it will become like this. So this is the anterior end. Not that. This is the anterior end. And I picked up the basket. That is the posterior end, still attached to the vertebral column. And this is the left side. And this is the right side. And I've lifted the diaphragm. Okay. This lifting of the diaphragm is done to show this. I want you to learn two things. One is I want you to see that there is an opening for inferior vena cava, there's an opening for esophagus, and there's an opening for aorta. And sometime later on, we'll talk about these openings. So these are the three openings in the diaphragm for the two major big blood vessels to pass through and the esophagus to pass through. Also, if you notice that there is a central trifoliate tendon, a tendon which is there right in the center of the diaphragm, and it is shaped like in the playing cards. You must have seen there's something like this in the playing cards. This has got 3 leaves. And because it has got 3 leaves, it's called trifoliate. And that is the trifoliate central tendon of the diaphragm. That is the insertion of the diaphragm. The whole diaphragm is a very complex muscle. When we go to respiratory system, we'll see its complexity. Remember that it is taking origin from every bone that is there in that area. The vertebral column, lower 6 ribs, left side, lower 6 ribs, right side, and sternum anteriorly. So it's taking origin from sternum here, this part. Posteriorly, it's taking origin from the vertebral column. And here you can see very nicely it is taking origin from the lower ribs. All the bones that are there, it is taking origin from. So for its attachment, there is no bone remaining. And its attachment is going to be in the central tendon. And how this happens that without a bone, it is getting attached. This is because of embryology. And when we are doing RS, we will again touch upon this very fast and very quickly. Not today, after doing RS. Okay, so this is the section, this is the thing we see. Now I'm taking coronal sections. That means it will go like this, from anterior to posterior. So if we take sections from anterior to posterior, then this is how it will have to be there. So this will be the heart, which is in the center. This is the heart. Okay, and these are the 2 lungs. What I want you to understand is that the right side of the heart is in complete contact with the right lung, and the left side of the heart is in complete contact with the left lung. It's actually like the 2 lungs are overlapping or hugging the heart. The heart has got less space. The lungs are occupying all the space. That is very important. The rest of the diagram you forget. This is just to show you, this is the spleen. This is the transverse colon. This is the lung. And whatever we see in the X-ray film, sometimes we just talk without understanding anything. So this is the costodiaphragmatic angle. This one, because this black line is the pleura, and that is the lung. and there is a lot of space between the pleura and the lung, which we will see in respiratory system, in anatomy as well as in physiology. They will explain to you how the lung becomes big. This is the posterior view of the heart. Okay. In posterior view, of course, we are not going to see or do anything. Just for explanation, this is SVC, IVC, this is IVC, this is the right atrium, this is the left atrium. Because the 4 pulmonary veins are opening into the left atrium. Atrium is always the receiving chamber of the heart, and ventricles are the pumping chambers of the heart. So the 4 pulmonary veins will come into the left atrium, and the 2 superior and inferior vena cava will come into the right atrium. But the blood from the right atrium and the right ventricle cannot mix, because there is an interatrial septum, which is there in between, inside. And this interatrial septum, which is there inside, is demarcated on the surface by an interatrial groove. Similarly, I showed you interventricular septum. There is an interventricular septum here, which separates the blood from the right ventricle from the left ventricle. And on the surface, it is demarcated by an interventricular groove. So inside there is a septum and outside there is a groove. This is the continuation of the interventricular groove posteriorly. This much is the posterior interventricular groove. This is the right ventricle and that is the left ventricle. Wherever the apex is wholly formed only by the left ventricle. Always the apex is formed only by left ventricle. So this is apex, so this has to be left ventricle. So this is right ventricle. So everything fits into place. Below right atrium, right ventricle. Below left atrium, left ventricle. Between left atrium, between the left ventricle and the right ventricle, interventricular groove. Okay. Now, in this particular diagram, inferior surface is somewhere here, which we are not able to see. So what I'm showing you is, see, now when you are seeing only this part of my hand, this is the posterior surface. And the fingers, you can also see the fingers now in this diagram. That is inferior surface. And especially if I do like this, like that, then you can see posterior as well as inferior surface together. Okay. But this is if we take out the heart and see, then we can see posterior surface and inferior surface together. But when it is in the body, the inferior surface is sitting on the diaphragm like this, and we can see the posterior surface only and not the inferior surface, because inferior surface is in contact with diaphragm. It's only if we take it out of the body, then we can see the 2 surfaces in one view. So here it is asking, is this the posterior surface or the inferior surface? So this much is the posterior surface, and this is the inferior surface. This is because we have taken out the heart. So forget about this. We are not going to do this. This is to give you an idea. This will be the inferior surface, which is sitting on the diaphragm. Please remember, heart is not lying on the diaphragm. We won't use the word heart is lying, because heart never gets a time to lie down. Heart is always sitting on the diaphragm. Because if the heart will ever go to sleep, we will be dead in few seconds. So heart is always sitting. It is never resting. It is never lying down. It is sitting on the diaphragm. This is again to show you all the walls together. This is the posterior surface. This is the inferior surface. And this is the anterior or the sternocostal surface. We don't have to remember all this. This is no longer needed for us. So we can skip those details. Right? That was only for all, just for info. Forget about rest, anything that we spoke about till now. Now, have you ever heard of infarction occurring in the atrium? No. Have you ever heard of anything about the atrium? No. Reason is, atrium is never considered important. Atrium is like Sautela, no, like Anath. Forget about it. Don't talk about it. Talk only about ventricle. Every cardiologist will talk about ventricle. Nobody will talk about atrium. The reason is that the wall of the atrium is thin compared to the wall of the ventricle. The wall of the atrium is thin compared to the wall of the ventricle. The wall of the right ventricle is 3 times thinner than the wall of the left ventricle. Okay. If the wall is thin, then the question of ischemia occurring in that wall is much less, because the size is thin, blood supply is somehow or the other going to it, and ischemic changes cannot occur in the wall which is thin. And that's why atrium does not have any infarction ischemia, and that's why we do not talk about atrium. We just skip atrium, forget atrium, and we talk about ventricle and ventricle. Again, in the ventricle, as I'm telling you, the wall of the left ventricle is 3 times thicker than the wall of the right ventricle. It's something which is good to know for GK. It has got nothing to do with other things. Other than that, the infarctions will occur more common in the left, in the part of the heart which is supplied by the left coronary artery, which is because it's going to basically supply the left ventricle. What I want you to keep in mind is that this interventricular septum, septum's wall is not only made by left ventricle, but also the right ventricle. So left ventricular wall and right ventricular wall together will make the interventricular septum. And therefore, the interventricular septum becomes one of the thickest walls of the heart. And therefore, lots of chances of infarction because it is the thickest wall. Okay. Keeping so much in mind that it is only the ventricle which is, because of its size, that is thickness, if there are likely chances of infarction occurring in its wall, we will learn the walls of the ventricle. Basically, if you see that the wall of the atrium is thin enough and the wall of the atrium is thin enough so that infarction chances in the wall of the atrium is hardly anything. But because the thickness of the left ventricle and the right ventricle is much more, chances of infarction are more. What is infarction? We'll do later on. Today we are just doing anatomy. As we go ahead, we'll do things. Okay. So first and foremost thing, the heart is divided into 2 parts, the left and the right side. The left side of the heart contains oxygenated blood. The right side of the heart contains deoxygenated blood. The 2 atria are meant for receiving the blood and pushing it down to ventricles, and ventricles are responsible for pumping out blood to the body. Therefore, now we'll coordinate the anatomy with the function very soon. Right now, we are still learning anatomy. And then we will see why the anatomy is like that. So blood of the left side and the right side of the heart can never mix because there are interatrial and interventricular septums, correct? But the blood coming from any atrium, the left or right, will go into the left or right ventricle. And where it goes into the ventricle or from the atrium into the ventricle, this opening is guarded. This opening is guarded by something which we have learned as the tricuspid and the bicuspid valves, right? Or the mitral valve. We have learned these words, and today we have to see these words, right? And so now I'm going to start making you think, and we are going to think. So now imagine this is the atrium on the top. Okay, this is the atrium, one atrium. Okay, and this is the ventricle below. 2 hands. What happens is that first the blood fills up in the atrium. After the blood has completely filled up in the atrium, then only the atrium contracts. When the atrium contracts, the ventricle which was empty, now it starts filling up with blood. Okay. Now the ventricle is full of blood. When the ventricle is full of blood, the ventricle will contract. Now let's see this. Atrium is relaxing, blood is filling up in the atrium, ventricle is empty. When the atrium will contract, blood will start collecting in the ventricle. When the ventricle is collecting blood, correct, atrium has finished its contract and it is started to relax. And when the ventricle is completely filled with blood, it will contract. By the time this will start relaxing to receive more blood. That means what you know, what you have already heard, is when there is a contraction of the atrium, there is relaxation of ventricle. When there is contraction of ventricle, there is relaxation of atrium. You already heard this, you have learned it many times. Now, if you put medical words in it, contraction is called systole and relaxation is called diastole. So when there is diastole of one, there is systole of the other. When there is systole of this, there is diastole of that. This is what you already know. So see now, if this is the atrium, this top one, and if this is contracting, the impulse from the atrium is now traveling to the ventricle. Please understand this, forget mechanical function. Let's now do electrical function. And then I'll teach you there are two things called electrical and mechanical function and how they go hand in hand. When the impulse will come to the atrium and the atrium is fully stimulated, the impulse will pass to the ventricle and the ventricle will get stimulated. So before the atrium finishes its total contraction, ventricle without filling will start its contraction. Because the impulse is going like this from the atrium to the ventricle. But this does not happen. We have been taught when there is contraction of the atrium, there's relaxation of the ventricle. That goes to tell you that the impulse is not going from atrium to ventricles. If the impulse is not going from the atrium to the ventricle, that means atrium muscle is not connected to ventricle muscle. Because if it was connected, nobody in the world can stop the impulse from going. That means between the atrium and the ventricle, there is something. There is something between the atrium muscle and the ventricle muscle which prevents the impulse from going immediately. And that's something which is there in between is called the skeleton of the heart. Okay, that is one reason of skeleton. We'll see many reasons for skeleton. Okay, and then we'll see the skeleton itself. But right now I'm teaching you the muscles of the ventricles and let's do that part. So right now we are talking about the ventricle muscles. So if we see the ventricles muscle, there are some muscles which you see which are looking like a pillar, right? Which are looking like a pillar. Pillar, of course, you have seen many places. This is a pillar. Okay. So this is a pillar. These muscles are like this. Now the things that we see in the wall in our house, that one pillar is going like that from the floor to the roof, and it is also going to the other person's house and from there above and all. These we call columns. These we don't call pillar. These are called columns. A pillar does not have an upper end which is attached to anything. Upper end is free. If the upper end is attached to something, then the word used is column. And therefore, there are lots of RCC columns in our buildings. So pillar is something which is free. And the Greek word for pillar is papilla. Papilla is the Greek word for pillar. Okay. So there are a lot of papilla on our tongue, which are just projecting like that, like pillars. So that is same papilla. And therefore, these muscles which are projecting like this till here, these are called papillary muscles. You can see all of these papillary muscles. This one, this one, this. Let's see in another diagram. These papillary muscles have been cut when we took the section, right? This is a papillary muscle. This is a papillary muscle. This is the actual specimen of the heart. You can see the papillary muscles. Huge papillary muscle. Big one. Another big, huge papillary muscle. Left ventricle, so all muscles are bigger in size. This is another papillary muscle. This is a papillary muscle. So one type of muscle which is found in the muscles of the ventricle is called papillary muscle, right? And these papillary muscles are attached by their base to the ventricular wall. Full stop. Let's see. They are attached by their base to the ventricular wall. Base of the papillary muscle is attached to the wall, part of the ventricle. So it is a part of the ventricle. You can see here we cut it. So it is a part of the ventricle's muscle. Whereas on its free surface, that is on their apex, there are attached small fibrous cords known as chordae tendineae. And these chordae tendineae are attached to the cusps of bicuspid and tricuspid valve. So starting fresh and not drawing anything, showing you directly. This is papillary muscle attached, a part of the ventricles muscle. It is a part of ventricles muscle. It is a part of the ventricles muscle attached to the ventricle. At its apex or free border, there are small fibrous cords known as chordae tendinae, and chordae tendinae are attached to the cusp of tricuspid and bicuspid valves. See this? The chordae tendinae are attached to the tricuspid and bicuspid, whereas this is the pulmonary and this is the aortic. It's not attached to them. Okay, so this is attached to this cusp. These are the cusps. These two are the cusps. These are the cusps. So they are attached to the cusp of the tricuspid and bicuspid valves. Okay, so there is a word called valve. There is a word called cusp, and we have to see all these words and understand their meaning. Now, in this diagram, in this section, this type of section, if the ventricle contracts, that means this papillary muscle is going to contract. If this papillary muscle is going to contract, because the papillary muscle is attached to the cusp of this tricuspid and bicuspid, it will pull the tricuspid and the bicuspid cusp downwards towards the ventricle. Please note that when the ventricle will contract, it will pull the cusps towards itself, that is towards the ventricle, and therefore the tricuspid and the bicuspid opening will remain open and blood will go from the ventricle back into the atrium. This is what has to happen because it is a muscle of the heart. It does not happen due to some other reason. What I am trying to make you understand is that if there is a rule has to be followed. Okay, so now we'll have to get another force which will prevent the pulling of the cusps down towards the ventricle, so that then the cusp can remain like this. So we'll need two more forces, different forces. But what we are learning is one thing, and that we have to learn properly. So if this is the ventricle's muscle, when it contracts, it is going to pull the cusp downwards. Therefore, the opening will be open. Keep it there and we'll go ahead. Now, this is the skeleton of the heart. What you can't see, you can't understand. So forget about it. Let's now draw things and talk. Okay. Now I'm making my house, and this is one wall of my house, and I want to put door here. So naturally, where I want to put door, I'm not going to put bricks and make a wall, because then again I have to break the wall. So in the brick wall, there is an opening. Please understand that these are all bricks, of course, covered with cement and everything. But the brick part of the wall, I have left out a space which is going to be for me to go from this room to that room or that room to this room. You have left out a place. Now I go to the market and I get a door. A ready-made door, size of which is correct, same size which is there in the wall gap, and I've got a door. If I take this door and put here on this door, even if it is fitting correctly, it will fit correctly, but then I can't use it as a door. I cannot open it and close it. There is a door, there is a gap. So let's call the gap the hole. So the black gap which is there in the wall, that we'll call hole. And this is the door which we have put red color. Now this door has to be fixed to this wall by means of one frame. I have to make here one frame, either wooden, aluminum, whatever thing I want. I have to make a frame here. And on this frame, I have to attach this door. So there has to be a frame. And the door is put in that frame and close the opening. So let's see. Opening or the hole is closed by the door. Correct? But this door has to be attached to this wall by means of a frame. Between the right atrium and the left ventricle, there is no opening. There is a hole. Correct? There is a hole. And I want to put a door on it. So I am bringing a 3-cusped door. I am getting a door which is having 3 cusps. And therefore I call it tricusp. 3 small doors which together make one big door, which is going to be fitted between the right atrium and the right ventricle. A combination of three small doors, which is going to look like one door. But where do I attach this door? Because there is an opening between the right atrium and right ventricle. If I put this there, it will just move away with the blood. Unless I have attached this door nicely to something between the atrium and the ventricle, I have to attach this to something nicely. If there is a framework to which I attach it, then it will remain there. And if the blood is coming from the atrium, it will open towards the ventricle. And if the blood is coming from the ventricle, it will open towards the atrium or whatever, not open, etc., etc. But it can move provided it is attached to something. If it is not attached, it itself will walk away. So this place where it will get attached is between the atrium and the ventricle. Right? So the skeleton of the heart is situated again in that same coronary sulcus. Level will be coronary sulcus, and it is a fibrous tissue which is like this in nature. This diagram, which will be like this in nature. And you can see this has got 4 holes. So when I say it's a skeleton or it's a plate, let's say it's a fibrous plate. It's a fibrous plate like this, which is placed between the atrium and the ventricle. And in that plate, there are 4 holes. And it is to this frame, black one, that the tricuspid and the bicuspid valves are attached. They're attached here, right? The word valve is again also wrong. Valve is not the correct word. It is the cusp. It's the movement of the cusp which is the valve. There is no thing as valve. Valve is a movement. That's why when we go to fill air in our scooters or four-wheelers, that fellow presses on some valve by which air enters into the tire. When the valve gets pressed, the air can go in. Valve is not something which is, it is a movement. Anyway, we will not split hairs. Let's take the bicuspid and the tricuspid to be valves. So these valves are attached to the skeleton, which is a part of the fibrous tissue, but there is a gap left out in between for the blood to flow out and into the heart. So this is exactly how the skeleton will look. And most important is the atrium muscle will come and get attached to the skeleton, something like this. From above, this is the atrium. These muscles are attached to the skeleton. So this is the attachment of the skeleton, where of the atrium, whereas the ventricle muscles are attached like this. So there is no continuity between the atrium and the ventricles muscles. And because there is no continuity, there is no continuity of the conduction. The nerve impulse cannot go from the atrium to the ventricles because ventricle is attached here and atrium is attached here. In between, there is a fibrous skeleton. The muscles of the atrium, we are not going to do in details, but when we go to ventricle muscle, I'll talk to you about its attachment. So the skeleton does 2 functions, very important. One is it gives attachment to the atrium muscle one side and ventricular muscles on the other side, and it acts as a base in which there are openings where we can attach the tricuspid, bicuspid, aortic, and the pulmonary valves can be attached to it. You understand that the valves are closing the opening. The opening is between the atrium and the ventricle. And for the cusp to be attached, there needs to be some framework. And it is the skeleton which is called the framework. Right? So this is all stories. You can just read it. This is the basis of the electrical discontinuity. That's why the atrium and the ventricles will not contract at the same time. Of course, the last line is in normal people, sometimes they become incompetent or stenosed also. Okay, this is just to show you that the frame part of it, the frame part of the skeleton, the rest of the skeleton for attachment of muscles is removed. This is the frame part. So these are the three semilunar aortic, red in color. So you see this, now I'm drawing one U. So this is one semilunar, this is another semilunar, and this is the third semilunar. These are the aorta cusps. And same red color continuing, this is the mitral valve, where mitral valve will get attached inside this framework. This is where the tricuspid will get attached, correct? Because this is blue in color. So this is where the tricuspid will get attached. Okay. And this is where the pulmonary valve will be there. Also, another thing that is there is when we again go to electrical, I will tell you that, okay, I'll tell you that when we do electrical, okay, forget about it. We'll come back to this slide C and go back to it. Okay. So what happens is now the section is taken with the atrium, which is above, which has been cut. See where the section is taken exactly at the atrioventricular groove or at the atrioventricular sulcus. Atrium, which is above, is removed, and we are looking at the ventricles from above. This is the bicuspid cusp, two of them. These are three cusps, so this is called tricuspid. The cusps are attached to the skeleton, and when the cusps are closed or open, then the opening is closed or open. Here, this is the pulmonary, this is the aortic, and when the pulmonary and the aortic are open, the bicuspid and the tricuspid have to be closed. Or if the bicuspid and tricuspid are open, then the pulmonary and the aortic have to be closed. So right now, when this section was taken, it was the ventricles were contracting, and therefore these two are open and blood is going out of the heart. Again, in the same section, we can see this is the right coronary artery which has been cut, and this is the left coronary artery which has been cut. Telling you that this is at the level of the atrioventricular junction, at the level of the coronary sulcus, at the level where there is the skeleton in the heart. This I want you to see, especially, see, this is, of course, diagrammatic. So we have shown all valves close to show us bicuspid, tricuspid, aortic, and pulmonary. So both of them have got three cusps which are semilunar in shape, and therefore they are called semilunar cusps. We'll talk about these two cusps little later. But what I want you to see is this is the opening of the left coronary artery, and this is the opening of the right coronary artery. The openings of the coronary arteries are visible. Because they're visible means blood is going to flow into them. That's what I'm trying to tell you. Blood is going to flow into the coronary arteries only when the aortic valve is closed. Only when the aortic valve is closed, blood will flow into this. And this will pick up again when we start coronary arteries. We are going to see this diagram again. Okay. This is the functioning of the valves. To show you the functioning of the valves, one side is TS, one side is LS. So these two are LS and these two are TS. Okay. When the atrium is contracting, this diagram, when the atrium is contracting, the blood is going from the atrium into the ventricle. Correct. See the size of the papillary muscle. It has contracted and it has become so small. It has contracted and become so small. Blood is coming into the ventricle. At that time, pulmonary or the aortic, whichever is shown here, this is closed. Let's see in TS what is happening. Pulmonary, that we are doing this, sorry. Blood is coming here. So the tricuspid is open and the bicuspid is open and the blood is going from the atria into the ventricles, and pulmonary and the aortic are closed. If you move here, then when the tricuspid and the bicuspid are closed, that is blood is going from the ventricle into the aorta. So the tricuspid or the bicuspid is closed. Can you see how it is closed like this? Like a straight line. This is one cusp, this is one cusp. This is like this closed. And therefore blood cannot go back into the left atrium and blood is going into the aorta. And the aortic is opening. Same way the pulmonary is open. Now, if the cusp has to be like this, one cusp and one cusp, we are seeing only in two directions because I've got only two hands. We are seeing the cusps like this, two of them closed. Okay. Now, what we saw here previously is when the papillary muscle contracts. When this papillary muscle is going to contract, papillary muscle by the means of chordate tendon attached to the cusp, and it is going to pull the cusp downwards. Please remember that. It's going to pull the cusp downwards towards the ventricle. If it pulls the cusp downwards towards the ventricle, naturally the blood from the ventricle will go back into the atrium also, because this is open, and it can go back into the atrium and it can go into the pulmonary. So the blood can go into the pulmonary as well as back into the right atrium. But we don't want it to go into the right atrium. Now, how to do this? So now we have to learn what is biophysics. We are going to learn biophysics. This what we learned was just contraction of the muscles. So with the ventricles contracting, even the papillary muscle will contract. Remember that? And it will pull the cusp downwards. Now let's see this. Where am I drawing? So inside the ventricle, there is blood. Correct? This blood which is there inside has got some pressure by itself. It has got some pressure by itself. Okay? When the ventricle muscles will contract, there will be a force created. This force from the ventricle's wall is transferred onto the blood which is inside the ventricle, so that the force which is now acting on the blood is called hydrostatic pressure, or the pressure of the blood which is inside the ventricle. That is under pressure because its walls are under pressure. Walls are contracting, and the contraction of these walls, the force is transferred onto the blood. Because it is transferred onto the blood is under pressure. It is full of pressure. Because it is full of pressure, what the blood will do is the blood is going to put the cusp towards the atrium. See this? The hydrostatic pressure of the blood is going to push the cusp towards the atrium. Okay? So now both have gone towards the atrium. Whereas at the same time, the ventricle which is contracting and its papillary muscle which is contracting was trying to pull the cusp towards the ventricle. See, now there are two opposing forces. The papillary muscle is trying to pull it down, and the hydrostatic pressure of the blood is trying to push it up. In between the two, there is a fight. One is pulling it down, one is pushing it up. And in between the two, it comes and stops here, where the two forces equalize each other. So it comes and stops here, and it remains here. So actually, there is a fight going on. Ventricle papillary muscle pulling it down, hydrostatic pressure of blood pushing it above. Between the two, it comes and stops there. It's in a fight where it has come and stopped. And because there is a fight, and in the fight, whenever there's fight, there's a lot of noise. You know that, right? And because that two are fighting and the cusps are closing exactly like this. Exactly like this. See, the cusp is like this in straight line. The ventricle was trying to pull it. Papillary muscle was trying to pull it like this. The hydrostatic pressure of the blood was trying to push the cusp like that. In between the two, the cusp is coming and lying here, absolutely in between the two. So the fight between the two is almost equalized. And because there is a fight, it is closing with a noise. And that noise is the first heart sound. So we say the first heart sound is produced by the closure of the atrioventricular valves. So it's not just smooth closing. There's a fight, and because of fight, that when it is closing, it is making a noise. And because of that, the first heart sound is produced. So this is no longer like we are learning contraction and expansion, this movement. We are understanding now why this is happening. And if you understand why this is happening, then we can understand. Let's, for a minute, go away from the heart. Go away from the heart, and we'll understand something, come back to the heart. Then we can understand the walls of the heart landscape. See, we have to remove from the abdomen what is known as F's. Fluid, that is urine, feces, fetus, flatus, all these have to be removed from the abdomen into the environment. Now, to remove something from inside a closed cavity, first there has to be an opening. Okay, so we have kept openings in the anal canal, in the urethra, this, that, etc. for it to come out. Opening is there. How is it not coming out throughout the day? Why urine is just not flowing out throughout the day, just dripping all over the place like animals do? That is reason is that this is collected in a bag, like urinary bladder, in the rectum, the stool is collected, whatever, blah, blah, blah. But if it has to be expelled, thrown out from the abdomen, of course, provided there is an opening, then the pressure inside the abdomen has to increase. Pressure inside the abdomen, that is intra-atrial pressure, has to increase of the abdomen. If the intra-abdominal pressure has to increase. If the intra-abdominal pressure increases, this intra-abdominal pressure is transferred onto the feces or onto the urine. And when that is transferred onto that, then that can be expelled provided there is an opening. If the pressure inside the abdomen has to increase, every wall of the abdomen has to be made of muscles, because muscle is the only tissue which can contract. So by contraction of the walls of the abdomen, we are increasing intra-abdominal pressure. And anyone who has constipation even little or hard stools little know what contraction and what increase of the pressure means, right? How people strain to pass stool. So we're increasing intra-abdominal pressure. If intra-abdominal pressure has to be increased, all walls of the abdomen have to be made up of muscles. Only muscle can contract. If muscle can contract, the space can become narrow. If the space becomes narrow, the force of contraction is transferred from the wall to the contents. Okay, that is simple logic. That is called pressure transfer. Okay, that is pressure transfer from the wall. And therefore, all walls of the abdomen have to be made of muscles, and they are made of muscles. Anteriorly, there are muscles. Laterally, there are muscles. Posteriorly, there are muscles. Of course, there's just one vertebral column. That's a different story for the attachment of muscle. Superiorly, there is muscle called diaphragm. Inferiorly, there is a muscle called pelvic diaphragm. And therefore, all six walls of the abdomen are muscular. There's a wrong word in Hindi. घर के चार दीवार होते, घर के चार दीवार नहीं होते, 6 दीवार होते, नहीं तो ऊपर वाला हमारे घर में आएगा और हम नीचे वाले के घर में जाएंगे. So all 6 walls of the abdomen are muscular, and that's why intra-abdominal pressure can be increased. Same way, when these walls of the ventricle contract, and you see the difference in the size, right? So the walls of the ventricle have contracted. When the walls of the ventricle have contracted, naturally the whatever is there inside this, here the pressure increases. The pressure inside the blood, the pressure of the blood, or the hydrostatic pressure of the blood. If you want big Greek physics word, hydrostatic pressure of the blood or simple pressure of the blood increases, and this was going to push the cusp to the atrium. The ventricles contracture was pulling it down. In between, they came together like this, closed, and they closed with the sound, and they closed with a noise, and that noise we translate into first heart sound. And first heart sound is formed with closure of atrioventricular valves. Okay, time being, I'm skipping the pulmonary and the aortic valve. And let's see something else, which is more important because our topic right now, what we were doing is ventricles wall. If you remember, we are doing walls of the ventricle. We have done skeleton and we have done the papillary muscle. Now we are seeing something else. The interatrial septum, which is not important for us. It's not important. Just for writing, we have written. Just for reading, we are reading. Interatrial septum runs from the anterior wall of the heart backwards and to the right. Forget whether it went to the right, left. So interatrial septum is from the anterior surface of the heart to the posterior surface of the heart because we don't want blood to mix. So it is a full wall between the two atrium. Okay, forget. Let's see what is important. The interventricular septum, this is placed obliquely in its position. I will show you and I'll make you understand what I'm saying. But first I want you to read what it is. And the interventricular septum, which is inside the heart, its attachment on the surface of the heart is indicated by two grooves, the anterior and the posterior interventricular grooves. So seeing this much, let's go and see this. So this is the atrioventricular groove or sulcus between the right atrium and the right ventricle. We are not talking about this. We are not talking about this. We are talking about this. So the interventricular groove, which is between the right ventricle and the left ventricle, which is here. So just some figures I'm taking just to make us understand. Just for understanding, if you see the front surface of the ventricles, then this is more towards the 2/3 of the right and 1/3 of the left. Approximately, they're just talking words, showing you that is here. Now, if I say that the interventricular septum is straight like this, going from anterior to posterior, exactly like this, then when it goes posteriorly and we see posteriorly, it should be somewhere in this line. If it was straight, then it should be somewhere in this line. Then it would mean that the interventricular septum is like this. Now, what I am trying to tell you is that the interventricular septum is placed like this, obliquely, not transversely, but obliquely, like this. So if you're seeing this as the anterior border of the interventricular septum, posterior border will be here, not like this, not in the same straight line, like this. That means we will not expect posterior interventricular groove to be in line with this, but it will be somewhere here. It should be somewhere here, posterior interventricular groove. If posterior interventricular groove was here, then interventricular septum would have been like this. Anterior interventricular groove, posterior interventricular groove. It would have been like this. It is like this. So this is the anterior interventricular groove and this is the posterior interventricular. It is like this. Now let's see the posterior diagram. I can't find a good one. Okay. I'll have to go through many slides. This is the posterior interventricular groove. This is the posterior interventricular groove. And this is the anterior interventricular groove. This artery which is lying, this is lying in the anterior interventricular groove. And that artery is in the posterior interventricular groove. So posterior interventricular is not here in this line. It is more like this. So it is more towards the right side and the anterior interventricular groove is more towards the left side. That is what I want you to understand. It is not straight. Yes. That's very nice. This, you see this septum, interventricular septum, how thick it is. It is going from one side to another side, anterior to posterior, but obliquely. That is, it is going from the left towards the right side. This way. It is going like that. Whatever, if you want to see this as my anterior, then that is the posterior. It is not in the same straight line. Anterior posteriorly, it is lying obliquely. That is what you have to understand. One. Secondly, you have to understand that it is the thickest wall. This okay. So this is the interventricular septum, thickest wall. Please remember that. Again and again, I'm telling you this is thickest wall. And sometime I'm telling you today that sometime I'm going to tell you wrong things about the, not today. Later on, I'll tell you something wrong about the interventricular septum, and I'll make you believe it that what you're telling is correct and what I'm telling is correct. And you will tell yes. Though it will be wrong because you have forgotten interventricular septum is the thickest wall. Okay. So interventricular septum, we read till here. The lower part of the septum is thick and is formed of muscle. Muscle coming from the right ventricle and muscle coming from the left ventricle. Whereas the top part, superior part, means part towards the atrium, is thin and it is membranous. This is where it is with the skeleton. Is it attached to the skeleton? And that part becomes membranous. And it is membranous for the simple reason that you must have heard of a bundle of His. There's SA node and AV node, and after AV node, this bundle of His. And then the fibers have to go into the ventricle. So they have to go through that part, and that part on the top, this part is membranous, rest is all thick and very, very muscular. Now, what happens is, just for that 1 second, let me show you. Impulse which is starting here in the SA node travels through both the atrium and comes to the AV node, right? Thin walled, easy to travel, travels very fast, small in size atrium, message goes around, impulse goes very fast, stimulation will occur, atrium will start contracting. Again, we'll come back to this tomorrow or some other day, not today. But then from AV node, it goes through this, through the skeleton. Now remember, since we are going towards the ventricle, it has to go through the skeleton of the heart. And from that skeleton of the heart, the first part of the interventricular septum, that is membranous, to allow this bundle of His to pass through that. If it was thick and muscular, every time the ventricle will contract, the bundle of His will get crushed. So that it will not get crushed, the part with bundle of His passes, that is membranous. Then see, this is the thickest wall. And the impulse has to go from here to here to here. And the impulse has to go from here to here to here. And remember, this is a cut section. The impulse also has to go anteriorly, and impulse has to go posteriorly, towards the left, towards the right, in both the ventricles at the same fraction of a second. Both the ventricles have to contract as one big ventricle. Please understand that. Therefore, impulse has to go, if the impulse has come here to the bundle of His, in the same fraction of a second, it has to reach this point and it has to reach this point. Same fraction of a second. It has to reach both the points so that both the ventricles are fully stimulated at the same time. And both the ventricles at the same fraction of a second have to contract. If this has to happen, then only both the blood will come out of both the ventricles at the same time. If this does not happen, blood cannot come out of the ventricles. For this to happen, there are some reasons. One, if we see gross, the muscle of the ventricle is in the shape of figure of 8. It's in the shape of figure of 8. But 8 is written in 3 dimensions. This 8 I have written in 2 dimensions. You have to write the 8 in 3 dimensions. How we write in 2 dimensions, something like that. So that the muscle itself is in the shape of figure of 8 in 3 dimensions. So the impulse can pass very fast because of its shape. It is not like shaped like a triceps or biceps or straight muscles or cylindrical muscles. It is turning on itself. That is one reason. Second reason is that the muscle of the heart, which I told you in the first slide, is branching. So if I take this muscle, one part of this branch has gone and met with this muscle. This branch part of this is gone and met with this. And again, remember, we are seeing two-dimensional. We have taken a section and we are seeing that section under the microscope. So we are seeing two-dimensional. In reality, this same muscle that we are talking about, this cell, this particular only one cell, is also going to give out a branch backwards. It's going to give out a branch forwards, right? So the branches will be in all directions. These are all three-dimensional. Remember, we are talking about it in two dimensions. And where each muscle cell meets another muscle cell, there is some dark thing. Where this meets like this, all these dark, these are called intercalated discs. Similar to the word intervertebral discs, right? Though you're looking at a flat line, remember each flat line is disc shaped. That means it is three-dimensional. Disc means something like a chapati, something like pizza bread. Disc is like that. Okay, it's three-dimensional. We are seeing two-dimensional. So we are seeing it as a line. This intercalated disc, the good old times, people said that the impulse from this cell will go to this cell very fast. And from this cell will again go to multiple cells very fast. Each adjacent cell, the impulse is going fast. One. Second is because each cell has got branches by which it is attached to different cells, it is able to pass the message on to multiple cells at one time. It is not 1:1. There's 1:4, 1:5 like that. The impulse is going to 5 cells. And because of these two properties, the impulse spreads into the whole of both the ventricles at the same fraction of a second and will stimulate the whole of the two ventricles so that both the ventricles can contract as one unit. Now, people pointed out if that there is something like an intercalated disc, something is there in between. Something like intervertebral discs are there between two vertebrae. There's a cartilage there. So if there is something in between, then how can the impulse go faster? It should become slower. So they said maybe the disc is acting like a catalyst, and that's how it is sending it forward. This was all supposition until the electron microscope came in the 1960s. Electron microscope, under electron microscope, we can see everything of the cell, right? And then we came to know that the cell wall is not, I'm taking this example, no? Cell wall is not like this. This cell wall, when we see under the microscope, is like this. This cell's wall is like this. And the other cell wall is also like this. So that the area of contact between the two cells is much, much more than we can see. And therefore, the impulse can pass faster. And the each cell is having branches by which is attached to multiple cells. And therefore, the impulse goes very, very fast. And that's how the impulse travels in the whole ventricle, both the ventricles together in that same fraction of a second. And both ventricles together contract as one big ventricle, right? Not as two different ventricles, neither parts of the ventricle. It is the whole full ventricle. And this is the reason. One is cells are branched, intercalated disc increase the surface area for stimulation, and this myocardium is in the shape of an alphabet 8 in 3 dimensions, of course, right? And that's how the impulse passes very fast. What is the impulse and what is the passing of the impulse? We will do tomorrow, not today. Today we are seeing little structure. Tomorrow we'll do more of function. Or maybe this is the last or the second last slide, and then we'll be stopping. There are basically 3 layers of the heart. The inner one is called endo. By now you know in Greek endo means inside, and its opposite exo means outside. Exo means outside. Correct? whatever is the muscle, the Greek word for muscle is myo, and therefore the muscle of the heart is called myocardium. The innermost lining, I'm not going to talk for the 1 minute, but the outer one, right? The outer covering of the heart is called pericardium. And I'm not going to teach you anything about pericardium. After we finish respiratory system, we'll do pleura and pericardium together as one unit. And that time we'll talk about pericardium. So pericardium, I'm not talking at all at present. Okay, pericardium we are going to leave, but just names will do, but not detail of pericardium. This pericardium which is there, right? Whether it is pericardium, whether it is pleura, whether it is peritoneum, all three, in all three, the two words are common. One is parietal and one is visceral. Somebody has unmuted themselves. Since only 5 minutes are there, I'm not talking anything more. Don't worry. So one is visceral, another is parietal. That means, no great thinking, but let's do here. There should be one more slide. Okay, skip it. We said the slide, we will not finish. We'll see here only and we'll see whatever it is. So there is this is the pericardium. The pericardium which is in contact with the organ, whatever is the organ, that will be known as the visceral. So since this is in contact with the heart, this one is called the visceral pericardium. And the one which is the other one, this is called the parietal pericardium. Now the word parietes means wall, W-A-L-L, wall. It does not mean outside. That means the pericardium or the peritoneum or the pleura, which is in contact with the wall, is called parietal pericardium. And the one which is in contact with the organ is called visceral pericardium. Right? So that is how the meaning is. We'll do this later on. But whatever is inside, that is the inner lining of the heart, which will be continuous of the inner lining of the aorta. So the blood which is coming out from the ventricle, the inner lining of the heart, that is endocardium, is going to become continuous as the innermost lining of the aorta. And same way, the innermost lining of the superior vena cava and the inferior vena cava will continue as the innermost lining, that is the endocardium of the heart. So the endocardium of the vein becomes endocardium of the heart, becomes endo of the aorta. This innermost layer of the blood vessel is known as intima. This one. This is known as the intima layer, or this is also known as endothelium. Endothelium, which is inside. So endothelium of the blood vessel and endocardium of the heart is continuous. Right? Though it has got different names, like we know there is a road name is different, and after some time the road name is different, doesn't mean there are two different roads, doesn't mean we have to pick up our car from this road and put it on that road and then drive. It is one continuous thing. They are given different names. The endothelium is inside the blood vessels and endocardium is inside the heart, but it is one continuous structure. And as long as the endothelium remains intact, endothelium and endocardium remains intact, that means it does not break, there is no intravascular clotting. Intravascular clotting will not occur. This is very peculiar. Intravascular clotting, that means clotting of the blood inside the heart or inside the blood vessels will not occur just because the endocardium is intact. If the endocardium or the endothelium ruptures, breaks open, then only the blood clot will occur. Please understand this very carefully, that endothelium is the only one due to which clot is not formed. So when you want to know why is there a clot formed in CAD, in coronary artery disease, read today. And if you can't understand, ask me tomorrow. Okay? But if you read, then only I'll answer. I will not do your homework for you in the class. I would like you to ask question telling me that, yeah, this is where you got blocked and you couldn't go ahead, and then I'll finish the answer. Please remember this very carefully. Intravascular clotting does not occur if the endothelium is intact. And how there is a clot in the coronary vessels, how there is a clot in the deep venous thrombosis, DVT in the calf, right? These are the two main questions that I would like you to think about. With that much, we will stop. I'm stopping 2-3 minutes early because I want you to ask questions if you want to ask questions. Can you talk to me? Somebody just try talking. I want to know whether I've unmuted you. Please unmute yourself and talk to me. Tell me you have no questions or ask a question. Can you hear me? Has someone taken over as the co-host? Has Dr. Pallavi made somebody co-host? If so, please unmute everyone. Are you all there also? Not there? I don't know. Only Swardha Pawar has written no questions. Why don't you talk to me? Yeah, Sarosh Khan, you have raised your hand, I can see, but what are you trying to tell? Why you are not able to talk to me is what I want to know. Can you unmute yourself? Somebody has unmuted themselves. Okay. Deepanti Biswas, you have unmuted. Yeah, many people. So none of you have got any questions, correct? Pardon?
Yeah.
Who wants to ask question?
भी ले रही हूँ अपॉइंटमेंट मिलता है तो
अरे अपॉइंटमेंट छोड़ो, क्वेश्चन का क्या करने का? Okay, I'm taking it for granted you have no questions. Tomorrow when we start again and again ask you if you got any questions, you can tell me. To that.
Okay, sir.